Okay, so today we are going to see the practical number 22, that is the spirochetes, which there is some problem. There is some problem with my application. This free conference app. I don't know what is that, but I think we'll start with it. So we'll start with it. Today's practical number is 22. This is the practical number 20, that is about spirochetes. We are getting started with what are the spirochetes that we have to learn, and what are these spirochetes, that the practical aspects of each of the spirochetes which are pathogenic mainly to the human body. So now we're starting with the general idea of what is the spirochetes. The spirochetes are the thin, flexible, elongated, spirally coiled helical bacilli. Okay. So the spira, that name comes from the spira, that means meaning is the coil, I mean the cheetah means there is a hair. So they belong to the order Spirochetes, and they have two classes. So class 1 is the Spirochetaceae, that consists of 4 genera, that is Spirocheta, Christispira, Treponemas and Borrelia. Then the second class is a Leptospiraceae class, which has in 2 genera, that is the Leptospira and Leptonema. Now the cell wall of the spirochetes is similar to that of the gram-negative bacilli. Okay, so we have learned in detail about the gram-negative bacilli cell wall in the general microbiology part. Now it is similar to that one, only the difference from the GNB is that it is having a flagella. Also the gram-negative bacteria also has a flagella, but that is an exoflagella. Here we have these spirochetes bear a endoflagella. So the cell wall is similar as I told you. So it consists of outer membrane and the inner membrane, that is the cytoplasmic one, and the peptidoglycan layer. And there is a space between this outer membrane and peptidoglycan layer, that is known as the periplasmic space. And here that the flagella of the spirochetes resides. So this is also called as the periplasmic space containing the flagella. Therefore it is called as the endoflagella. The ultrastructure of the spirochetes, if we see here, we can see that if we see the cross section of this one, the spirochetes, here what we can see is the three-dimensional view, that is the electron microscopic view of the spirochetes. In here you can see this is the bulging, that is nothing but an axial filament. Okay, so what is the role of this axial filament? It's a locomotive organ. That is nothing but here you can see the axial filament. If you do the cross section from this area, you can see there is a outer membrane, there is the inner membrane, there is a cell membrane, and there is a outer membrane. In between that there is a periplasmic space. Okay, so that is the periplasmic space. This periplasmic space, at a particular space, at this particular site, there is so many endoflagella. Okay, the endoflagella are here at this periplasmic phase. So there is a bulging here. So this bulging is known as the axillary filament. This is due to the endoflagella resides there underneath that outer membrane. Okay, so therefore it's the axillary filament where we can see that these are endoflagella, where we can see the endoflagella in the cross section, and these are the organs of the locomotion in the spirochetes. Here spirochetes associated human diseases. So when we can see the human diseases which are caused by the spirochetes are mainly the genus Treponema. This is the species Pallidum. The common species Pallidum is there, but there is a subspecies difference is there. According to the subspecies, we can see the disease is happening. So Treponema pallidum subspecies Pallidum causing disease syphilis. Treponema pallidum subspecies endemicum causing Beagle. The Pallidum subspecies Pertinue causing yaws. and the species Caratium is causing Pinta. Okay, so depending upon the difference in the subspecies, there is a different disease. So most commonly we are associated with the syphilis, that is due to Tetroma pallidum subspecies pallidum. In the Borrelia, most commonly Borrelia burgdorferi, that is the species which is responsible for this Lyme disease, and the Leptospira interrogans, that is the species which is responsible for the what is known as the leptospirosis or the Wells disease. How will you differentiate between these pathogenic spirochetes? So when we see the pathogenic spirochetes, Borrelia, Treponema, and Leptospira, in this order we are going to see what are the differences. This difference because in this order I told, because this is a order has been decided depending upon their size, the length and the thickness. Okay, so in the length wise also and in the thickness wise also, this Borrelia is more lengthy and more thicker as compared to the Treponema and Leptospira. Okay, so this is the size 10 to 30 micron in length with up to 0.5 micron in width, that is the thickness. The treponems are 6 to 14 micron with 0.2 micron in the thickness, and Leptospira are 6 to 20 micron in length. There may be a slightly more length than the treponems, but they are thinnest of the spirochetes. That is, they have a 0.1 micron only thickness. The spirals, depending upon the length, we can see the spirals also are 3 to 10 in number in Borrelia. So these are the spirals. Okay, so these are the spirals. Here, according 10 to 30 micron of their length, they have minimum 3 up to maximum 10 of these such spirals can be noticed. And there is also, due to this spirals, there is a length of the spirals is approximately 3 micron of each spiral. Like in Treponema, we can see spirals are 6 to 12 in numbers with the spiral length is less, that is 1 to 1 micron, up to 1 micron in the length. And in Leptospira, if you see, there are numerous spirals. The spirals are not numbered, okay, outnumbered, okay, because here we can see they are tightly coiled spirals can be seen, okay, and there is size wavelength of this each spiral is approximately 0.5 micron. And one more interesting about this is there is the ends, which you notice there is a hooked end, okay, so like a hook, the ends are particularly hooked end of this Leptospira, which is not present with the Borrelia and Treponems. Even the endoflagella which are present, they are 7 to 11 numbers in the Borrelia, the only 3 to 4 numbers in the Treponema, and only point to be noted that is the only one endoflagella is seen in the Leptospira. Okay, so these are the diagrams of these each spirochetes and their differences. Now we move on to the particular disease, that is the syphilis. So if you see the syphilis, it is caused by the Treponema pallidum, we know, discovered by the Schaudin and Hoffman in 1905. And they have particularly, due to their endoflagella, they have particular corkscrew motility. Okay, the corkscrew motility is definitive of this Treponema pallidum, and one of the things is they cannot be cultured in any artificial media. Okay, as we do in the other bacteria, we grow them in our artificial media like McConkey blood and all other special media, but these species Treponema pallidum will not grow in an artificial media in the lab. How they are transmitted, you know, this is the syphilis is a sexually transmitted disease. So there is the first highest chance of transmission is by sexual contact. Second, transplacental from the infected mother to their fetus. Third, percutaneous, that is contact with the infectious lesions. And fourth is the blood transfusion. So therefore, whenever a blood donation has been performed, before giving it to the patient, needy patients, that donated blood is screened for this syphilis disease. Okay, so and then only it's given. So that is the way of transmission of this syphilis. In cultivation, we know they cannot be cultivated in artificial media, but they can be cultivated in the animals. Okay, so therefore there is Nicole strain. There are two strains are there. First is the Nicole strain, which is a highly pathogenic and highly virulent strain, which is cultivated in serial testicular passages of the rabbit, and it is isolated from a severe tertiary syphilis patient in the year 1912. From 1912 to till date, they are keeping its serial testicular passages in rabbits and maintaining this strain, which is known as a Nicole strain. It's a highly virulent strain. And then the Rater strain. The Rater strain is a non-pathogenic treponemes are there from that, but it's showing the similar morphological and antigen characteristics with that of the Treponema pallidum. So therefore, this is the Rater strain which is mainly used for the diagnostics purposes, okay, of the syphilis. Now we can see this is a natural history of the untreated syphilis. So that is important, untreated syphilis. Here we can see there is the inoculation, that is the first contact with us due to sexual contact or blood transfusion or maybe any other way. The treponemes enter into your bloodstream. Then in 10 to 90 days, so the 10 to 90 days is their incubation period, average is about 3 weeks, they will end up into the primary syphilis. Primary syphilis means the syphilis where the visible chancre and all lesions can be seen first after the entry of the virus. After the entry of this treponema, the first appearance of the clinical features will be the primary syphilis. What are these we will going to discuss in the next slides. Then after that primary syphilis typical lesions, there is a hematogenous dissemination after that, and after this first appearance of this chancre, that is the skin lesion of this particular syphilis, after 3 to 10 weeks of this appearance, then the patients land up into the secondary syphilis. So there is again clinical features are different of the secondary syphilis. What will happen after secondary syphilis has been started? After the secondary syphilis has been started, 3 to 12 weeks period time, the lesions will start within that period disappearing spontaneously. So that is the criteria of this syphilis, natural history of syphilis, that the lesions automatically in 3 to 4 weeks they started to disappear and totally disappear within 12 weeks without any treatment. Okay, so that's why whenever patients having such lesions, they will shy to come to the STD clinics and they will wait for some time. And due to the waiting some time, due to this natural history of this disease, there is a disappearance of this lesion automatically without any treatment. So they feel that they are free of this disease, but this is not the case. So what will happen if they don't turn out to take the treatment and the lesions will disappear? They feel they were cured. So what will happen? 25% of such cases in the infection or 1/3 of such cases will land up into immediately in next 1 to 2 years. They will end up into the relapse of the again secondary syphilis. So they will again land up into the relapse of the secondary syphilis up to 25% to 1/3 of the patients. Then what about the remaining 70%, around 70% patients? They may get cured, but the rate is very less. So the 70% of patients in the very long time in the life up to 20 years, 2 to 20 years, it is a long time. So someone is having the syphilitic lesions, they will forget in next 10-15 years, and they will develop slowly they will develop a tertiary syphilis, that is involvement of the visceral organs during this period. So that is a natural history that we must know about the natural history, because in which stage the patient comes to you, whether it comes to a primary syphilis stage, secondary syphilis stage, or latent syphilis, or the tertiary syphilis, that you have to rule out, and according to that you have to advise the test to be performed for the laboratory for the diagnosis. Okay, so that we should know the natural history is more important. So these are the lesions of the primary syphilis. Here the primary syphilis starts as a painless, erythematous, indurated papule. So that is an ulcer which is painless. So therefore they will not, they will generally ignore it because of it is painless. If it is pain there, they will go to the doctor immediately. So it's a painless first, then erythematous and the indurated. And it has the margins are the well-defined margins. Okay, well-defined, non-tender and indurated. And the primary site is the where they get contact with the treponemes, like genital contact. So genital area, perineal area, anal area are the common area where such lesions, ulcers will develop. Okay, and most important of this is whenever the ulcer develops, they are also associated with their local lymphadenopathy. So commonly inguinal lymph nodes are always affected in such patients. Okay, and they are the bilateral lymphadenopathy will be there, and these are the typically multiple discrete lymphadenopathy, and if you feel it, it's like a rubber. Okay, you are feeling like a rubber. Okay, so that is the rubbery feeling of that lymph nodes is the characteristics of this primary syphilis. The secondary syphilis, so that is the lesion, the general lesions are common, and then after 3 to 10 weeks, it will land up into the secondary syphilis. So first they will have a generalized low grade fever, malaise, sore throat, body ache, and lymphadenopathy must be there, and then they turn out into the followed into the mucosal rash, that is a skin rash. First is the skin rash. So the skin rash is typically copper colored, evanescent, macular type of rash. Okay, and due to the macular type of rash, after some time it start developing and affecting symmetrically affecting papillary depression on the trunks and the chest and the. So the macular rashes will appear symmetrically on the trunks and back, and then followed by to the both the extremities, and palms and soles also get involved, because the rash of this some other diseases having also rash, but they spare the palms and soles. But here the syphilis is particularly affecting palms and soles as well. Okay, so there may be a starting with the macular rash, they may turn into the papular one as the time passes, and there may be a pus formation in this one. So there may be a various variants will be there, like pustular and all other variants also can be seen in the skin rash of the secondary syphilis. Then the mucosal lesions also important. Near about 30% of these patients, secondary syphilitic patient, will show mucosal lesions. So though this is a typically mucosal lesion which is slightly raised, oval in shape, grayish white appearance, a grayish white membrane will be there over the surface of this lesion, and will be removed that membrane, you will see a pink base which does not bleed. Okay, so this non-bleeding type of the oval area can be seen mucosal lesions. So the typical lesions can be seen over the mouth mucosal area, tongues, and even vaginal mucosa. Okay, so this is the mucosal typical lesions. And then the next term is a condyloma lata. There is a condyloma lata is a particular term given to this type of the lesions. That what are these lesions? These are the large, you can see the large, raised, and the whitish, grayish type of lesions can be seen in the perineum area, because these areas are the moist and warm, so where the treponema can be large in the number. So in such moist and a warm area, there is a formation of such skin lesion that is known as a particularly of the condyloma lata, whitish, raised, and the large one. Okay, but these lesions are highly infectious. So whenever if there is any contact with this lesion, so there will be the patient or the other person will get immediately infected. Then the latent syphilis, we know the latent syphilis, the patient already covered from these secondary lesions, and then there will be latent phase. Due to latent phase, the positive syphilis serologic will be there, but it is having no any signs and symptoms. So that is the thing. The patient is having no any signs and symptoms, but if you do the serological testing, so it turned out to be a positive one. So that has to be noted. Then the 1/3, as I already told you, 1/3 of the untreated patients land up into the tertiary syphilis, and there may be a relapse. Also, there may be a relapse of the secondary type of syphilis. But if the patient take a treatment within primary secondary phase, then definitely there will be a total cure of the disease in the right time. So what is the tertiary syphilis? Tertiary syphilis is very slowly progressive. Okay, therefore it takes within 2 to 20 years in their lifetime. So whenever patient is having the syphilitic lesions in their young age, in 20s and 30s, when they going to into the 50s and 60s, they will develop the involvement of the visceral organs. So there is a too much huge life span. It's already lost in that one. Okay, so that has to be remembered. So these tertiary syphilis, they remain 3D type. That is, the gummatous lesion can be seen. There may be a cardiovascular syphilis, cardiovascular involvement, and the neurosyphilis, that is the central nervous system involvement. So in this cases, it is very hard to treat such syphilitic lesions. Okay, so they may land up in such cases like can be crippling or life-threatening conditions, or they may come with the blindness, deafness, or deformities or any time, or dementia-like features of the tertiary syphilis because of involvement of the deeper organs. Okay. So this is the final chart of showing the primary, secondary, latent and tertiary features, how much they progress, what are the clinical symptoms, how much time will do it take, and what is the evidence. So it is the healed primary lesion, that is chancre, will heal in 3 to 6 weeks. Okay, and here secondary will also heal, but it takes more time, weeks to months. But here latent phase, no clinical features, but only evidence is the positive serological test, and this is the very tertiary, is very widespread, rare but widespread disease, and use of the antibiotic is very important in such case. Now we move on to the laboratory aspects, that is the laboratory diagnosis of the syphilis. How will you test the syphilis? The syphilis can be tested by the two methods, that is microscopically or the serological testing. As we know, there is no role of the culture here, as they cannot be grown in an artificial media in their lab. Okay, so the microscopically point, we can do the, not even they are thin and cannot be visible under the light microscope. Therefore, the special microscope like dark ground microscopy, phase contrast microscopy, or fluorescent microscopes can be used to see the this Treponema pallidum under the microscope. So, what are the methods? The direct microscope, direct fluorescent antibody testing, and silver impregnation method. So we'll see what is the silver impregnation method. Okay, then serological ones. Serological means we can identify the antibodies formed against that treponemal antigen. So these are two types of serological tests. First is the standard test for syphilis. You know, already is asked in the exams many times. Standard test of syphilis, which is known as a non-treponemal test, and there is a treponemal test, that is a specific test for the syphilis. So these are the tests where the disease has been confirmed. And it can, these are the non-treponemal tests mainly for determining the activity, that is, this is how, whether it's progressive, it's the recovery is there. Mainly these purposes, the standard test of syphilis has been performed. So the how they are we go for the microscopy. So the primary, in the primary phase, whenever the patient comes, you have to see a primary chancre on the genital region. This is the most common lesion which has to be there. Then that lesion has to be cleaned with the gauze soaked with the warm saline, and their margins are gently scraped so that the superficial epithelium is abraded. Then gentle pressure is applied at the base of the lesion, and therefore the serous fluid which is come when you apply pressure at the base, so that serous fluid is full of the Treponema pallidum. So that fluid has to be picked up by you with on the slide directly, and a smear has been prepared and sent it directly to the laboratory. But that has to be clear, that should be a serous fluid. It should not get should not get mixed with the blood whenever you are collecting such samples. That has to be taken into the mind. Then we do, on such smear, we do the dark field microscopy, when we can see by the typical morphology and the characteristic movements, because some of the local other treponema will be there which are not pallidum causing syphilis. So other treponemas also look like a spiral shape. Okay, so how will you differentiate? The typical morphology which we have already discussed about the treponema pallidum, these are tightly coiled, and there is the ends are the hooked ends. Okay, so the ends are hooked and they are tightly coiled, and also if they are immediately transported to the laboratory, they are viable. Then there the corkscrew movement. Okay, because of the endoflagella, they are the motile ones. Okay, so that corkscrew motility can be observed under the dark ground microscopy. Okay, so that is the important. So here we can see the, as I told you, the other treponems also there. Here we can also do that whatever the serous fluid is also, if it is more serous fluid is present, it can be mixed with the anti-treponemal antibody, so that the motility of this particular organism is inhibited by this one, and this can be visualized under the dark ground microscope. Then the next more sensitive as of this is the direct fluorescent antibody testing of the Treponema pallidum. So here same sample collection is the similarly, only thing is that smear has to be stained with the fluorescein labeled anti-Treponema pallidum globulin. So the antibody against that treponemal antigen, and that antibody has to be coated with the fluorescein. So that fluorescent under the fluorescent microscope. Okay, so therefore that has to be mixed with the that serous fluid, and we have to examine it under the fluorescent microscope. Here we can see the nicely fluorescing spiral bacilli. Okay, so that has to be seen. It is also good for the diagnosis in early stages of the disease. Then the silver impregnation staining. So what do you mean by silver impregnation? Okay, so the first thing is they are the very thin and delicate one, so that cannot be visualized under the normal light microscope. So if I want to make them visible under night microscope, what you can do, I make them thick so they can be visible. They are already so thin so it cannot be visible. If I make them thick, they can easily visible under the microscope. So this is the silver impregnation method, is the method for making them thicker than they usually thin. So what will happen? The treponemes, they reduce the silver nitrate. So the silver nitrate has been added while staining. So that silver nitrate is reduced by the treponemes into the metallic silver. So they reduces the silver nitrate into metallic silver, and that metallic silver is going to coated or deposited on the surface of the treponema pallidum. So therefore the thickness of that treponema will be more. So they become a thick, and then you stain them with the either Levadetti stain or the Fontana stain. So Levadetti stain is particularly used whenever you do the biopsy of this lesion. So the tissue sections which can be stained with Levadetti stain, and the Fontana stains can be again directly stained for the smear which has already prepared previously with the serous exudate coming from that ulcer. Okay, so that is the important. So this is the diagram of this Fontana staining of this smear. Here after the silver impregnation method, you can do you can easily see now the spiral bacilli treponema pallidum particularly in this smear. Okay, so this diagram you have to prepare, you have to draw in the journals. The next is the serological testing, that is antibody detection, which is commonly performed in every lab, and here is the standard test of syphilis and the specific test. Only the difference I already told you, again I will tell you, that is this is the detection of the reagent antibody. What is the reagent antibody? The reagent antibody is the antibody which has formed against the substances which has been released from the cells which are infected with the treponema pallidum. Okay, so that you must know, that is the treponema pallidum infecting a cell, that is destroyed, and whatever it is the substance has been released. On that that released the substance, against that the antibody has been created. So that antibody is the reagent antibody. So therefore it's not a specific. Okay, here it's not a specific to the treponema pallidum. So this reagent antibody, when we are going to detect it in the in vitro test, we use a cardiolipin antigen against this antibody. So using a cardiolipin antigen in the test, so that is the for detection of the reagent antibody. So these tests are called as the standard test for syphilis or non-treponemal test. The specific test, treponemal test, is the where we can directly use specific antibodies using the treponema pallidum antigen. So itself the antigens of the treponema pallidum is used in this case. Therefore it's more sensitive and specific, more specific I should say, more specific for the treponema pallidum infections. So what are the tests? The list of the tests. So non-treponemal test, first there are the old methods are the Wassermann complement fixation and tube flocculation test of Kahn. So Kahn's tube flocculation test and Wassermann complement fixation test, these are the old one, we are not using it, but now we are using as the VDRL, that is the Venereal Disease Research Laboratory test, RPR, that is Rapid Plasma Reagent test, and TRUST test, that is a toluidine red unheated serum test. So these are we are doing commonly nowadays in the laboratory for the diagnosis. Then treponemal or specific tests are also important. You must know the names and how they are performed. The TPI, that is treponema pallidum immobilization test. FTAABS, again here fluorescent treponemal antibody absorbed test. Then TPHA, that is treponema pallidum heme agglutination test. TPIA, that is the treponema pallidum immune adherence test, and TPPA, that is treponema pallidum particle agglutination test. So you must know these names of the test: the TPI, FTABS, TPHA, TPIA, and TPPA. Okay, because it's helpful in the diagnosis. How they are going to tell you. The important thing about a non-treponemal or standard test is that we can do both qualitative and quantitative tests. Qualitative will check for the presence or absence, only the presence or absence of antibody. But quantitative, whether we check whether the amount of antibody is present in the serum. Okay, so we can have a titer in this VDRL, RPR, and TRUST test. Okay, so the titers are important. We can measure them, how much amount of antibodies are present in the serum. Now we will see the VDRL test. We know Venereal Disease Research Laboratory test is a test used for the on the patient serum for the diagnosis of treponema pallidum. Here the serum is directly not used. Here it has to be inactivated because the serum itself contains some of the non-specific inhibitors or the globulin or the complement systems and all this. So whenever we apply a cardiolipin, there will be a cross reaction. Okay, antigen will be added. So therefore these non-specific inhibitor has to be removed or maybe deactivated. So they are deactivated or inactivated by just heating this serum sample. So whenever you receive a serum from a patient, you have to heat it in a water bath at the 56 degrees Celsius for at least 30 minutes. Okay. So after that, then the serum can be used for the testing of by this VDRL test. Then so this is helpful in the prognosis and recovery of this. After heating that for the 56 degrees Celsius 30 minutes, then we remove it, take a drop of this. So this is a VDRL slide where you have to perform this test. So this slide has been, we have this slide in our department as a spot, and we can show you when you come into the department, and when you see this, and this has been kept for your spotting examination. Okay, so they identify and what is the test required and all things. Okay, they can ask you question on this tile. So this is the tile where this is the particular tile which is having a wells. Okay, so these are the wells in the this tile. So this tile, this is the glass tile which is having the wells in that one. Concave well is there. So in that well we have to add a sample and antigen simultaneously, mix it. Here you can add it, you mix it, and then kept on the rotator for 8 minutes. Okay, after rotation has been completed, then this slide is kept under this light microscope. Okay, here on the stage we have to keep this slide, and then we can see, visualize the focus it on single well, and we visualize for the flocculation which can be visible under the light microscope. So this can be here is the weakly reactive will show flocculation in the some amount, and here the strongly reactive under the light microscope. So what are the results? How will you report it? So first with the reactive, that is strongly reactive, that means shows the strong flocculations and under the light microscope. So these can be reported as a past or a present infection with T. pallidum. Okay, whether it is treated, untreated, whatever, because in primary syphilis, tertiary, secondary syphilis may be there. Even in latent phase, in latent syphilis, there may be a past infection without any clinical features. Again, it may show positive, or maybe a false positive reaction. So that is also what is the false positive reaction we are going to see. Is there any problem with this? Can you hear me loud and clear? Is there any transmission error or something like that? Okay, so I again started. Okay, you can hear me clear and loud. Okay, ठीक. So if you see this, the reactive, the non-reactive, weakly reactive, and strongly reactive. Okay, so here we can see they are the strongly reactive ones that we have seen. There is a past or present infection with T. pallidum. In the weakly reactive, here is also there is a past or present infection or false positive reaction because of the titer change. Okay, so here we have to must do the titer. This is the qualitative test, and then you have to do the titration. Okay, so the serum has to be diluted and again reacted with this antigen to see the titer. So it is a highly titer. This serum must be having high titer. This is also positive, but it is the low titer. And the non-reactive means no current infection or effectively treated patient. So therefore it is important. Some patient is having in primary, come to you in primary secondary syphilis, you have done the VDRL test, experience positive, is having titer, some high titer, and again you have given the treatment, and it comes to after 1 to 2 months back, you record from that, and then you can see again ask for to doing the VDRL test. Then you will see the VDRL test, the titer is to be low down or the things come to be negative. So that means that treatment has helped him to recover from the disease. Okay, so that is what is important here in the non-treponemal or standard stage of syphilis. Here you can do that things. You can observe how the patient is improving, or there may be a worsening of the condition on the serology. Then where the important thing I mentioned here is the false positive reaction. So how they are come as a false positive? This false positive reaction is known as the biological false positive reactions. Okay, so this biological false positive reaction is defined as you must know the definition. What is the definition of it? So that defined as in a positive results coming in a non-treponemal test. So that like VDRL, RPR. In that the positive has been come strongly or weakly, whatever. So the positive has been come already in the VDRL or RPR test, but with negative results in treponemal test. So as we see in the treponemal TPI, TPHA, TPPA, these all tests. If you do the VDRL test coming positive, if you the same sample has been sent to the more specific treponemal test, in that test it comes negative. So that means there is a false positive reaction, again in the absence of past and present syphilis. So this is also important. If the patient is not having any current infection, or in the past he has an infection of the treponema pallidum, and still he is showing a positive result with VDRL, negative with the treponemal test, so that is definitely defined as a biological false reaction. That means a positive results in non-treponemal test with negative results in treponemal test, in absence of past or present syphilis, and in absence of any technical faults. So this is due to something else, that the patient is not having syphilis but still is giving the positive. So in what cases is giving? Because we are using cardiolipin antigen. Okay, so that cardiolipin antigen which we are using in this VDRL or PR test or the non-treponemal test, it is not specific for the syphilis. So it can be react with the other antibodies also can react with this. Therefore, the biological false reaction may occur in also in 1% of the normal serum patient. So what are the causes? Basically, the acute causes, that the viral infection, viral hepatitis, or any other viral infection, malaria case, in any acute injury to your organ, or any inflammatory conditions to your organ. Because of the destruction, there will be release of that, because the reagent antibody is acting against that one. Okay, so that is the, we have seen reagent antibody is the antibody which is reacting against the substance which has been released by the cells which are affected with T pallidum. But in these cases like viral infections, malaria, injuries, inflammation, pregnancy, here there is also injury of the cell, and they also release the substance against that already the reagent antibody acts on that. So therefore ultimately what happens? There is a false positive reaction. So here the chronic infections like cutaneous diseases, which is the most common. SLE, systemic lupus erythematosus, is the cutaneous and connective tissue disorders, which is commonly show false positive reaction with VDRL. Relapsing fever, lepromatous leprosy, and even malignancies like infectious molecules will show the false positive reactions with the standard test. Now we are moving on to the RPR. RPR is also a cardiolipin antigen has been used here, but only thing is that antigen has been stabilized by addition of EDTA reagent, and therefore the antigen has been stabilized. So VDRL, what will happen? We have to daily prepare the antigen and use it. But here that daily preparation of antigen has been not necessary, because the antigen has been stabilized with this EDTA reagent. And again, one more thing is choline chloride has been added to that antigen. What is the role of that? That choline chloride is eliminate the inactivate the unnecessary substances which are present in the serum, like complements and all. For that, what we are doing in the VDRL, we are heating the serum for 56 degrees Celsius for 30 minutes. But here only chlorine chloride itself will deactivate such agents. So therefore, there is again here there is no need of the preheating of the serum before the test. So that is the advantage of this test, that the antigen is stabilized and also preheating is not needed. Okay. So this is the advantage of this RPR test. And third advantage is that antigen is having a charcoal, that is carbon particles with that. Therefore, it is a black particle. So this is the test kit, a carbogen, the RPR test kit for syphilis. This is a positive reagent. This is the negative reagent already given into that kit, and this is the antigen. This is the antigen, which is black, having a black cap on this bulb. So that is the antigen, which is having a carbon particles along with the carbon antigen. So this is the card for the RPR testing. So in this card, the circles are there. Like here, you have to add the 1 drop of the serum and 1 drop of this arbogen antigen, and then mix here, and we will get directly see. If you put this carbon particle, we don't have to keep this slide under the microscope, okay, in the light microscope. That can be easily visualized, because these carbon particles can be clumping of this particle can be easily visualized by the naked eye. So that is the third advantage of using RPR over the VTRL test. So now is the interpretation of it. How will you interpret the results? If you perform both non-treponemal, that is the standard test, and the specific treponemal test, so then what is the possible explanation for such results? When both of them function, definitely the patient is having recent or previous syphilis. If the standard test is having positive but treponemal tests are negative, that means there is a no syphilis, or there may be a biological false positive. If the non-treponemal test negative, treponemal test positive, that is consistent with the previously treated, that is previously treated or untreated syphilis may be there. And there is both negative, there is a no syphilis or maybe a incubation period. The syphilis may be present in the, treponemal is present in the incubation period. So now, as I told you, depending upon the what type of test has to be prescribed in which condition, that we must know the patient is in which stages, whether it is primary, secondary, or in tertiary phase. So in that case, what has to be advised? What test? That FDA, VDRL, RPR, that is standard test will advise, or we go for the more specific one. So this is the FDA, this is the microscopy. So the microscopy primary is up to 80 to 100%. Secondary is 100%, and even latent phase 100%. So if the lesions are there, it will give more sensitivity and more positivity on FDA-ABS fluorescent microscopic antibody absorption test. Okay. Then VTRL is higher sensitivity and specificity in the secondary phase. So therefore, if you performing the VTRL test in tertiary or the primary phase, sometimes may you get, even the patient is affected with treponemal, it may show negative results. So that you must know. So in such cases, if you are suspecting clinically, and even if VTRL is negative, you have to move on to the more specific treponemal test like FDA-ABS or treponemal hemodialysis assay. Okay, so so this is all about the treponema pallidum lab diagnosis, what we have learned today. So it's more specific test, you have to go and read down yourself, that is what is the more specific test and how they have been performed to this one. Now we move on to the next is the leptospirosis. Next spirochetes is the leptospira. So this is a zoonotic disease, you must know, that is leptospirosis is commonly a zoonotic disease. There is no human to human transmission in these diseases, so that is good for us. Then the transmission by two methods, that is direct, indirect contact with the water or the moist soil which is contaminated with the animal urine. Okay, so there is the urine of the animal which is affected, the infected animal which is excrete the urine, so that is having loads of the leptospira in that urine. So therefore indirect contact, because the water or the soil may be soiled with this urine, so there may, if you contact in such water or soil, you may get infected. And second is the direct contact with that urine or the products of parturations of that infected animal. So that is direct or indirect contact. Then animals which are mainly affected with this leptospira are the commonly, so many 50 to 100 animals are affected with the leptospira, but commonly the rats, dogs, cattle and the pigs, they are the most susceptible, and from there the human get affected, because humans are more close to these rats, dogs, cattle and pigs. Okay, and these diseases commonly seen, peak of these diseases reported during the rainy season. Okay, so this is commonly in the rainy season or the post-monsoon season, we can see the peak of these diseases reported. Okay, because you know already. Then the pathogenesis, if you do the pathogenesis, the contact agent is come in the contact with this contaminated water and soil, and due to the abraded lesions or if abraded skin is there, they may leptospira will enter through that abraded skin by this contaminated water. When they enter into the abraded skin through our mucous membrane, they will first go into the bloodstream. So there is the first phase, that is the septicemic phase. Okay, septicemic phase is the leptospira enters the bloodstream and reaches to the different organs in our body. So Also, it causes damages or may go resides into the inner lining of the blood vessels. So they go inside and reside into the inner lining of blood vessel, resulting into the spread into the organ body, and then antibody will develop. But after that, there will be a severe diseases that will be leading to the ischemia of the or damage of the liver, kidney, and meninges and muscles all over. Okay, so hemorrhagic changes can be seen because it is present inside the blood lining and it's already spread to all the organs. So multiple organ involvement with blood vessel involvement is leading to the more severe case, that is the leptospirosis. So okay, so the first is the leptospiremic phase, that is the septicemic phase, where there is a non-fluoride general features, general symptoms like headache, muscle ache, eye pain, and all this can be seen, which is lasting for up to 1 week. Then what will happen? Then there is an immune phase. In the immune phase, what will happen? There is a antibody will form. That antibody will form and take care of this. Therefore, the fever is there, but in this case, and if you give antibiotics, the fever will not subside. So the antibiotic will not effective during this. They are not responsive. And then stiffness and more symptoms will be gone more severe, like inflammation of the nerves, eyes, sprain, and then stiffness of the neck and muscles, and all things will happen. Here the patient will excrete the leptospira in the urine in this immune phase. And the last phase is the Wells disease, that is the hepatorenal hemorrhagic syndrome. So because of the shedding of this treponema to the particular different organs, the hepatic renal organs, so the kidneys and liver get affected, and ultimately hemorrhagic changes will occur. This occur in 10% of the patient, and when it occurs, severe icteric form illnesses will occur, and there will be very severe fulminant or death can be happen in the short period of the time. In the lab diagnosis, again here what we can take as a specimen is the CSF or the blood. They can be taken for the first 10 days of infection, because of the blood is the most important. Septicemic will start immediately of the having the inoculation of the leptospira in the body, and then the urine can be done in the immune phase, because it's of 10 to 30 days after the infection. That is also important. So you can be seen in the urine. Leptospira can be seen in the urine. Then microscopically we can do their extremely thin, as we have seen already, seen their morphology. They are extremely thin. They cannot be seen under the light microscope. Here also we can do the dark field microscopy or the silver impregnation method, similar we have done in the Treponema pallidum. Okay. And then isolation, here this leptospira can be isolated in a media. Okay, so Treponema pallidum was not able to isolate in the vitro, but here leptospira we can isolate them in the artificial media. So there are obligate aerobes and slowly growing. So incubation period is incubation at 30 degrees Celsius, 4 to 6 weeks with pH 7.2 to 7.5. So the spatial media is the EMJH medium. These three names you must know. Okay, EMJH medium, Kortoff's medium, and Fletcher's medium. So this particular spira. So EMJH medium, the long form is the Ellingson, Macmillan, Thomson, and Harris media. It is a semi-synthetic liquid media. Okay, so this is a liquid media, semi-synthetic liquid media, having more and more nutrients in that liquid media. And here in the picture you can see the leptospira will grow and produces a dense ring. Here you can see a dense ring just underneath the surface of the medium. So here is the surface of medium. It's not the turbidity, uniform turbidity of this medium. Okay, so it forms a dense ring under the surface of the medium. So this is known as the Dinder's ring. Okay, so this is a Dinder's ring characteristically seen of the leptospira growth. Then Kortoff's medium is having the rabbit blood in that, and the Fletcher's medium, also semi-synthetic medium, can be used for the isolation of the leptospira. And the last is the serological identification, that is the antibody detection, commonly done because it's not cumbersome. So what are the other tests are available in the serology? The macroscopic slide agglutination test, lattice agglutination test, leptocheck dipstick test. In here we can detect only IgM. Then immunochromatographic test, that is a rapid test. Here the kit, and this is the test kits, and the ELISA definitely. Here ELISA and in immunochromatography we can detect IgM IgM and IgG, both antibodies separate. No. So what is the importance of IgM and IgG in a particular disease? The first phase, second phase, and all things. Okay. So here this is the case. You have to directly inoculate the serum and add the buffer, and you can see the control and the test band. Okay. So this is the control, both of them positive, M and G. Only M positive, only G positive. Okay. So this can be done easily in the serological diagnosis of the leptospira. Then next serological identification is important is the microscopic agglutination test, MAT, microscopic agglutination test, which detects antibody against the specific serovars of leptospira introgans. So here we use a antibody antigen specifically for detection of the antibody. So which antigen will use? Specific serovars of the leptospira introgans. So as we use a non-treponema test, here also it's more antigen detection. Antibody detection with the use of the more specific L introgans serovar antigen. Okay, by use of this antigen. This is the gold standard method, and it is also a reference method. So if any of these previous mentioned, like this microscopic agglutination, latex agglutination, and all things is negative, still you can do this MAT, that is microscopic agglutination test, and because it's a gold standard and more specific. ELISA is definitely more specific than this one. The patient serum is mixed in the microtiter plate, like in ELISA plate there is a microtiter plate, here also a microtiter plate. The patient serum is mixed, but the microtiter plate is already coated with the antigen suspension. Okay, so then we add the patient serum. The serum having the antibody, it reacts with the antigen coated over the microplate titer, and then the reaction will happen. 30 degrees Celsius will keep it for 2 to 4 hours for incubation, and this has to be examined under dark ground microscopy. Okay, so you have to observe this under the dark ground microscopy. You can see the presence of agglutination. Okay, if there is an antigen antibody reaction, definitely they will agglutinate it at a particular time. So this presence of agglutination will detect you like this, like here you can see the agglutination. Here are the single organisms are there. Okay, so the presence of agglutination can be seen under the dark ground microscopy. So at the end, there is the early diagnosis. Early diagnosis is a direct method of this leptospira can be done by the direct methods are some of the indirect. Direct means we can see the under the microscope, like immunofluorescence microscope, or staining with the silver impregnation staining, or you can do PCR also now available for this thing. Indirect method is doing ELISAs for various type for IgM and IgG antibodies separately, and micro agglutination test. By this method we can earliest diagnose the leptospira in the patient. So these are the we are at the end of this practical. So this is the spots which we are going to keep you in your exams. That is, on this topic of the Spirochetes, we can keep with the VDRL tile and as well as the RPR test kit. Okay, so this is the VDRL tile and this is the RPR test kit. So wait a minute, I will show you the okay. Now I will show you. Okay, can you see me? Because I am going to show you the VDRL tile and the RPR kit. Okay, so this conference call is not responding on my laptop, so I will not going to see what is happening really. I think you are going to see, I am visible to all of you, so I will show you. So this is a VDRL tile. Okay, so this is a VDRL tile. You can see this is prepared by the glass. Okay, so this is a glass tile and having some 6 wells on a single tile. So 6 wells, that means a concave. This tile is concave here. Okay, if you can see here, they are the concave wells are present. So that in that well we have to add reagent and antigen simultaneously and see and keep this tile under the light microscope. Okay, so under light microscope you can going to see the flocculation changes. Okay, the clumping can be easily visible under the light microscope because of this glass slide. So this is a VDRL tile which we are going to keep for your spotting. Okay, so this is the concave of the test. So if you know, when you come, you directly see how it looks like. And then second is the this is the carbogen kit. Okay, this is the RPR test kit because of from Tulip diagnostic, so it's a carbogen, but the name can be a different if you have a different manufacturer of this. So it's a RPR test kit. Okay, so the RPR test kit here, these are commercially available, and here you can see in that simultaneously you can see some this is again positive control, the red one which is having here, then the negative control is the green one again here, and then you have a this is the antigen. Okay, so this is the antigen. If you see, this is the antigen having a black color. Even you can see there are black carbon particles has been coated. So there is a liquid which is present here inside this bottle. There are black in color because of this antigen is having carbon particles as well. And then this you can see like in the tile, we are seeing the VDRL tile. So here are the this is the card. This is the card which is white in color. This card is available in this RPR kit. This card here in the circles, different circles are there. In single circle we are adding antigen and this carbogen. Sorry, in the one circle we add serum and this carbogen antigen, which is the RPR antigen with the carbon particles. So here under this white background we can easily see the clumping with your naked eye. Okay, so therefore you don't need to have a microscope for the seeing the results of this RPR kit. So therefore it is important. So this is the carbogen RPR test kit. This is also directly we have to going to keep on your spotting and will ask identify what is the test, what is the importance of test, and other questions on this similar kit. Okay, so these are the 2 spots can we keep on this practical in your practical. Okay, so